Hello and welcome back. In this episode, we continue our discussion of microcytic anemias by focusing on thalassemias and sideroblastic anemia. Now, even though most references categorize microcytic anemias similar to macrocytic anemias as anemias of underproduction, as opposed to hemolytic anemias, which are usually normocytic and associated with increased destruction, and as a result, we tend to consider all the microcytic and macrocytic anemias as anemias with low retic count, as opposed to hemolytic anemias, which are the anemias with increased retic count. Here we have a couple violations of the rules, and that's because one of the categories of microcytic anemia, the so-called thalassemias, are also a differential of the hemolytic anemias, and therefore we have microcytosis plus increased retic count. With that background, let's repeat our important question. What is the very first test to order in any patient with microcytic anemia? That's a patient with symptoms of anemia for whom we ordered CBC with differentials and RBC indices, and we figured out the mean corpuscular volume is less than 80 femtoliter. The very first next step will be ordering iron studies. And based on the results of iron studies, we could categorize our microcytic anemias into those with low serum iron and transferrin saturation, including iron deficiency anemia and anemia of inflammation, also known as anemia of chronic disease. Or we have the category in which we do not have low levels of serum iron, and those are the focus of this episode. They include thalassemia and sideroblastic anemia. I would like us to understand the concept of microcytic anemia as an anemia with impaired hemoglobin synthesis. Please compare this concept with hemoglobinopathies, which is a concept indicating abnormal hemoglobin, which is a differential of hemolytic anemia, such as in sickle cell disease. We can say they have some overlap in their conceptual relevance. However, here we are mainly dealing with decreased synthesis. Now, decreased synthesis of hemoglobin could be decreased synthesis of heme or globin. If you remember, the heme synthesis is a process involving several steps, and its relevance clinically is its association with some types of anemias as well as another diseases of impaired heme synthesis enzymes referred to as porphyrias. Porphyrias is not the focus today, but some of the enzymes of heme synthesis pathway is relevant to our discussion, especially the first and last step and the second step. So, now do you remember what was the very first step in the heme synthesis pathway? It was Alfa synthase, aminolevulinic acid synthase. And do you remember what conditions were associated with dysfunction or deficiency of this enzyme? Could have impaired requirement of the coenzyme vitamin B6, for example, in patients taking isoniazid, or we could have an X-linked mutation of the enzyme Alfa synthase. Both of these are the well-known causes of sideroblastic anemia. They impair heme synthesis, hemoglobin synthesis is impaired, the patient will have anemia. Now, the second and the very last stage of heme synthetic pathway could be impaired by lead poisoning. The second enzyme was Alpha dehydratase, and the very last step was ferrochelatase. This is why lead poisoning is a known cause of sideroblastic anemia, the anemia associated with impaired heme synthesis. Now, another question is why iron deficiency, as seen in iron deficiency anemia or anemia of chronic disease, is also associated with anemia. And the answer is, again, impaired hemoglobin synthesis. Why? In the very last step of heme synthesis, we have the incorporation of ferric iron into protoporphyrin by the enzyme ferrochelatase. If we do not have enough iron, this very last step that synthesizes heme from protoporphyrin will be impaired. Now the question is why copper deficiency is considered a cause of sideroblastic anemia. And the answer is copper is involved in cytochrome C, cytochrome oxidase, that converts ferrous iron to ferric iron, Fe2+ to Fe3+, and it's the Fe3+ that could get incorporated into heme synthesis. And then now we understand all the underlying causes for not only sideroblastic anemia, but for conditions associated with its famous peripheral blood smear or bone marrow biopsy findings, which are ring sideroblasts in the bone marrow and basophilic stippling in PBS. Okay, so this is the basis of why any enzyme deficiency, mineral deficiency, or genetic condition that impairs the heme synthesis pathway would cause anemia. Also remember that we have either impaired heme synthesis because of low iron level, or we have it because of other causes of heme synthetic pathway deficiencies. So in the other causes of heme synthetic pathway deficiency, iron is not incorporated into heme. So what do you think the level of iron, the serum iron, is going to be in sideroblastic anemias? The level of iron is going to be high. The high serum iron with microcytosis means sideroblastic anemia. Now you can see why I said iron studies that show anything but low serum iron, that includes normal serum iron or increased serum iron, are the focus of our discussion today. That is thalassemias and sideroblastic anemia. In thalassemias we have normal serum iron. In sideroblastic anemias we have increased serum iron. Okay, so this is impaired heme synthesis. And so what about globin synthesis? Well, we have hemoglobinopathies, decreased synthesis of hemoglobin or abnormal hemoglobins. Decreased synthesis of hemoglobins is seen in thalassemias. Abnormal hemoglobins is seen in conditions like hemoglobin S, hemoglobin C, SC, sickling, etc. All of these impairments of hemoglobin are also a differential diagnosis of hemolytic anemias with increased retic count. So this is the second exception, that all of our microcytic anemias are associated with low retic count except for thalassemias, because thalassemias are not only microcytic but also hemolytic anemias, and in hemolysis we have increased retic count. To make things even more complicated, remember that many of the transfusion dependent anemias, especially among the hemolytic anemias with chronic nature, such as thalassemia majors, because they require repeated transfusions, they are severe, in other words, transfusion dependent anemias. I'm talking about the thalassemia major, alpha or beta major. They would gradually have iron deposition, and therefore the level of serum iron could be high. So not only in sideroblastic anemia as the original pathogenesis of the disease, but even in the thalassemia, gradually after receiving a lot of transfusions, we may have even high serum iron. Yet another reason why I said we categorize these conditions, these four differentials of microcytic anemias, into those with low serum iron and transferrin saturation versus those without low serum iron and transferrin saturation, which means serum iron could be normal or could be elevated in sideroblastic anemia and thalassemia. Now, with that background, let's start our approach to microcytic anemia with normal to elevated serum iron. The first question is, if we have performed serum studies in a microcytic anemia and the results show normal to increased serum iron and transferrin saturation, what's the next step? Given the fact that our differentials are going to be thalassemia and sideroblastic anemia, we need to order peripheral blood smear. That's the very most important first test after serum iron studies. We also need to order serum lead levels as well as hemoglobin electrophoresis. What findings favor thalassemia? In PBS, we see target cells in both alpha and beta thalassemias. In alpha thalassemia, we could see acanthocytes. In beta thalassemia, we could see basophilic stippling. So A for alpha, basophilic B for beta. Now, just a reminder, as you can see, I've mentioned it here, in terms of differentiating from iron deficiency anemia, what's our RDW and Menser index? Menser index in thalassemia is less than 13, and RDW is not increased because we have evenly distributed microcytic RBCs. From now on, my focus will be thalassemias, and at the end we will discuss the sideroblastic anemia and lead poisoning. Now, I would like you to remember that there are several ways to differentiate several subtypes of alpha and beta thalassemia. We have demographic information, we have nature of genetic mutation or genetic abnormality involved, we have the degree or severity or presence or absence of anemia. As I already mentioned, we may have a specific finding in peripheral blood smear. And so you may be asked the patient with any combination of these findings, and you might be asked, what is the diagnosis? Is it beta thalassemia trait? Is it alpha thalassemia minor? Is it hemoglobin H disease? Is it beta thalassemia major? How do we differentiate alpha thalassemia major from beta major? How do we differentiate alpha minor or trait from beta minor or trait? What are the possible findings in 1, 2, 3, 4 gene deletions in alpha thalassemia? What are the epidemiologic data supporting each one of these cases? And yes, we unfortunately or fortunately need to know this. Fortunately, because I found a very neat and very exciting and beautiful algorithm, I made it here, that finally, at least for myself, made things very clear. Now, before we begin our clinical approach, I want to draw your attention to the genotypic differences and the nature of genetic changes. But before that, please remember that differential diagnosis of different subtypes of thalassemias are not based on genotyping, but based on clinical and lab findings. But for now, what is the underlying genetic abnormality on alpha versus beta thalassemias? In alpha thalassemia, we are dealing with alpha globin gene deletion. The severity depends on how many genes are deleted. If it is 1 gene deleted, we'll have silent carrier. If 2 genes are deleted, we have alpha thalassemia minor, also known as trait. If 3 genes are deleted, we will have hemoglobin H disease, which is severe anemia, sometimes referred to as alpha thalassemia major. If all 4 genes are deleted, we will have hemoglobin Bart's, which is gamma 4, incompatible with life due to hydrops fetalis and death in utero. What about the beta thalassemia genetics? Beta thalassemia is due to point mutations of beta globin gene, most commonly involving splice site or promoter region. The severity depends on whether or not we are dealing with heterozygous or homozygous mutations, the site of mutation, and severity of impaired beta gene product. So what are the different subtypes of beta thalassemia based on this genetic classification? We have thalassemia minor, which is either heterozygous beta 0 or heterozygous beta plus. Beta 0 means no beta chain production, beta plus means some beta chain production. Everything else other than thalassemia beta minor are due to homozygous mutations. So we have thalassemia intermedia if we have homozygous beta plus that is mild, that is mildly decreased production of beta globin chain due to mutations involving both chromosomes that carry this gene. Then we have beta thalassemia major, which is either homozygous beta 0 or homozygous beta plus, but this homozygous beta plus, contrary to thalassemia beta intermedia, is severely reduced production. Homozygous beta 0, of course, means absence of production. So as you can see, yes, the classification completely involves the genetic pathogenesis. However, there are other means than genetic testing to figure out the severity, and that would be based on the labs and clinical features. Now, before going through the labs, very exciting, very logically sense-making approach, I want us to remember, if you are dealing with alpha thalassemia major or beta thalassemia major, the patient is going to have severe anemia, and severe thalassemia is defined as transfusion-dependent anemia. If we are having minor, it's also called trait. The patients usually have mild or no anemia. The only situation or scenario that's left is that beta intermedia, that we do not have intermedia in alpha, we have just beta intermedia. In beta intermedia, the patient requires transfusion occasionally. Now remember, that may be the only thing that they tell you in a microcytic anemia with normal to high serum iron. So you need to pick the diagnosis as beta thalassemia intermedia. Alpha thalassemia is more straightforward. It's either silent carrier that has absolutely no clinical or lab finding, or it is hemoglobin BART, gamma 4, death in utero because of hydrops. We are not dealing with that. We just need to differentiate alpha minor from alpha minor, beta major from alpha major, alpha minor from alpha major, beta minor from beta intermediate from beta major. And by now you have some clues. However, if you are asked what is the number one most important test to differentiate these subclasses and we do not want to perform genetic testing, the answer is hemoglobin electrophoresis. So right off the bat, and for the very first differential diagnosis, if we have thalassemia, that's microcytic anemia with normal to elevated serum iron levels, we always have some abnormal hemoglobin in our hemoglobin electrophoresis, with one exception, and that is alpha thalassemia minor or trait. Even beta thalassemia minor or trait would have some abnormalities in hemoglobin electrophoresis, but alpha minor or trait will have normal hemoglobin electrophoresis. Please commit this to memory. Now, before going to analyze the abnormal hemoglobin electrophoresis for different subtypes of thalassemia, very important question. If we have a patient with normal serum iron studies and microcytic anemia whose serum hemoglobin electrophoresis is normal, what are the differential diagnoses? Remember our second category other than thalassemia, that is sideroblastic anemia. That is the important differential diagnosis. So the very important question right off the bat is, how are we going to differentiate sideroblastic anemia from alpha thalassemia minor or trait if no other information but the hemoglobin electrophoresis being normal, microcytic anemia, serum iron studies, and clinical pictures are provided? Well, that's the clinical picture. Alpha thalassemia minor is asymptomatic, but sideroblastic anemia will have symptoms of anemia. Later on, we would mention more important differentiating features such as ring sideroblast possibility in bone marrow studies that we need to perform in these equivocal cases, as well as serum iron levels in alpha thalassemia minor serum iron studies which show normal serum iron and transferrin saturation. In sideroblastic anemia, we will have increased serum iron. More on that in just a couple minutes. Okay, so the first subtype, alpha thalassemia minor. No anemia, normal hemoglobin electrophoresis. Now, one important thing you may hear about the alpha thalassemia minor or trait is cis or trans deletions. Cis simply means both deletions have occurred on the same chromosome, while trans means they have occurred on separate chromosomes. Now, what's the relevance of knowing this? Remember, cis deletion is more common among Asians, while trans deletion of alpha thalassemia minor occurs more frequently among patients of African descent. Now, one just genetic question again. Do you remember what chromosomes correspond to alpha gene versus beta gene? Yes, alpha gene is located on chromosome 11 and beta gene is located on chromosome 16. So what do you expect again in terms of clinical manifestations and lab findings in alpha thalassemia minor? We have the CBC, RBC indices and serum iron levels indicating thalassemia, while the patient has no anemia. Occasionally it's possible that patients have mild anemia. The hematocrit is more than 30%. PBS shows, as I mentioned, microcytic hypochromic anemia with possible target cells and especially acanthocytes that are seen in alpha thalassemias. Now, if you are asked what is the best test to confirm the diagnosis here, this is the occasion that we need to order genetic testing. Once more, what's the most important differential diagnosis of alpha thalassemia minor? Sideroblastic anemia, because this is the one with normal hemoglobin electrophoresis. Okay, let's now turn our attention to the meat and juice of the discussion. Yes, we are not there yet. That's the discussion to differentiate other thalassemias than alpha minor. Again, the most important test is hemoglobin electrophoresis abnormality. If we have a patient with microcytic anemia and normal to elevated serum iron with abnormal hemoglobin electrophoresis, that patient is 100% thalassemia, and any thalassemia possible but alpha minor. Before approaching a case that is highly likely to be thalassemia, what needs to be done for a microcytic anemia patient? We need to 100% rule out possibility of the most common anemia on planet Earth, the iron deficiency anemia. So even though we said serum iron studies, we need to also make sure by analyzing red cell distribution with, or it's more important, clinical equivalent Menser index, and to see a Menser index less than 13, that confirms it's not iron deficiency but it is thalassemia. Now, we mentioned the subtypes could be differentiated somewhat based on the severity of anemia. That's if they are transfusion dependent, it's going to be alpha or beta thalassemia major. But the most important differentiating feature here is going to be abnormalities in hemoglobin electrophoresis. And yes, we need to know what abnormalities exactly we are dealing with. Let me give you a couple rules of thumb. First of all, we do not deal with hemoglobin A2 in alpha thalassemia, right? Because if we have hemoglobin A, that means we have alpha chain. But in alpha thalassemia major, we have either beta 4 in hemoglobin H disease, or we have gamma 4 in hemoglobin Bart hydrops death in utero. We don't get to have hemoglobin A2 to be elevated. So if we have elevated hemoglobin A2, we are definitely dealing with a form of beta thalassemia. Also, please do not confuse hemoglobin F with hemoglobin Bart. Hemoglobin F is alpha 2 gamma 2, and again, because we have alpha 2, hemoglobin F is not going to happen in alpha thalassemia major. So it is a subtype of beta thalassemia, and as you can see, I've mentioned here beta thalassemia major, while hemoglobin Bart is gamma 4, that hydrops of alpha thalassemia with 4 gene deletion. Now, I would like to give you some reference numbers. In most standardized tests, you would see those reference numbers, or you would be provided some clues. Now, the term is elevated hemoglobin A2. If you hear that term, it means you are dealing with a type of beta thalassemia. Now, the next question is it enough to figure out the several subtypes of beta thalassemia? Well, if you know the patient is having mild anemia or is transfusion dependent or just needs occasional transfusions, you can say if it is beta minor trait versus occasional transfusion requirement in beta thalassemia intermedia versus transfusion dependent with severe anemia in beta thalassemia major. That's all you need to know. Clinical plus increased levels of hemoglobin A2. However, they may not tell you that the patient is transfusion dependent. It may be the first visit, the first diagnosis of the patient. So you would need another important clue, and another important clue is the levels of hemoglobin F. Regardless of the levels, remember this sentence. In beta thalassemia major, the predominant hemoglobin identified on hemoglobin electrophoresis is hemoglobin F. Hemoglobin F constitutes more than 90% of the entire hemoglobin in beta thalassemia major. So that takes care of figuring out the beta thalassemia major. It's a beta thalassemia, it is transfusion dependent with severe anemia, or it's an anemia with elevated hemoglobin A2 in which we have predominant hemoglobin as hemoglobin F. That's the story of beta thalassemia major, and how we differentiate it from other thalassemia with severe features or transfusion dependence, alpha thalassemia major. In alpha thalassemia major, we do not have elevation of hemoglobin A2. We do not have hemoglobin F as the predominant feature. We have hemoglobin H, which is beta 4 in alpha thalassemia major. Now, the very final, and perhaps the end of this exciting algorithm is how are we going to differentiate beta thalassemia minor from beta thalassemia intermedia and beta minor from alpha minor. Remember this, in beta thalassemia intermedia, not only hemoglobin A2 is increased, but hemoglobin F is more than 5%, while in beta thalassemia minor, hemoglobin F is less than 5%. It's still increased, because under normal circumstances, hemoglobin F should be less than 1% of entire hemoglobin. In beta thalassemia minor, hemoglobin F is increased, but its level is between 1 to 5% of total hemoglobin. In beta thalassemia minor, again, both hemoglobin A2 and hemoglobin F are increased. However, hemoglobin F level is more than 5%, up to 10%. But in beta thalassemia minor, normal hemoglobin, hemoglobin A, is still the predominant form. You are not going to be asked a question about the predominant form in beta thalassemia intermedia, but you just need to know that the value of hemoglobin F is increased more than 5%, but it is not the predominant hemoglobin as opposed to beta thalassemia major. I repeat this. In beta thalassemia intermedia, both hemoglobin A2 and hemoglobin F are increased, as in all beta thalassemias. However, hemoglobin F is more than 5%, and clinically, patient may require transfusions occasionally, and because of this full-blown hemolytic feature, the patient's reticulocyte count is also elevated, as opposed to no requirement for transfusion, normal retic count, and hemoglobin F less than 5% in beta thalassemia minor. Okay, so based on this, let's just ask a couple questions to practice this. How do we differentiate alpha major from beta major while the patients in both conditions will have microcytic anemia with normal serum iron or elevated serum iron, as well as Mensa score less than 13 and severe anemia that requires transfusion? Well, in alpha thalassemia major, hemoglobin H is seen in hemoglobin electrophoresis, which is beta 4. In beta thalassemia major, we have increased levels of hemoglobin A2, and the predominant form of hemoglobin is going to be hemoglobin F. Now, you may be asked, a patient has this level of hematocrit. You may not be told if the patient is transfusion dependent or the patient has severe anemia symptoms, etc. You may just be provided hematocrit level. You need to be able to understand the meaning of hematocrit in terms of severity of anemia, because that would possibly be your only clue to see if we are dealing with thalassemia major. The number is 30%. If hematocrit is less than 30%, you are dealing with severe anemia. And that means transfusion dependent thalassemia major. Okay, next question. A patient with occasional fatigue and dyspnea has normal RBC and iron indices, with the exception of MCV of 64 femtoliter. What's the next test to order? Now, the first question to ask ourselves in this case is, are we dealing with not only thalassemia, but possibly a sideroblastic anemia? And the answer is no. Why? Because in sideroblastic anemia, we usually have known underlying etiologies, and the patient usually has clear signs of anemia, and the patient usually have elevated serum iron. So the very next step in the assessment of this case is what is going to be hemoglobin electrophoresis. Hemoglobin electrophoresis results are reported to be normal. True or false? The next step is genetic testing or bone marrow biopsy. That's true. Now, we are dealing with possibility of alpha thalassemia minor, the only type that has normal hemoglobin electrophoresis. However, we may also be dealing with an initial manifestation of a sideroblastic anemia. Peripheral blood smear, bone marrow aspiration biopsy, lead levels, and genetic testings are all the next step diagnostic tests that could help us in this case. Now, how do we manage the thalassemia minor syndromes? They usually require no management in terms of iron supplementation or transfusion, but the most important thing is, given the fact that many such patients may be diagnosed by mistake as iron deficiency anemia, they may be provided with iron supplementation that has side effects So we need to just make sure that they know their diagnosis. We mentioned for beta thalassemia intermedia, they may require occasional transfusion, especially during the stressors and infections periods. Now, how about the management of thalassemia major syndromes? Most of these patients require frequent transfusions. That itself can elevate their levels of iron, so they should also avoid medicinal irons, and they would occasionally require iron chelators. The most important indication of iron chelators in thalassemia is the patients who require regular transfusions. The transfusion-dependent patients need iron chelators. We do not wait till organ dysfunction to initiate the chelators. Now, what other groups of medications should these patients avoid? Drugs that pose an oxidative stress to body, such as the sulfa drugs. What's another important arm of treatment in thalassemia major in addition to transfusion and iron chelators? Always remember folate supplementation. Now, when do the patients with thalassemia require splenectomy? If they get this hypersplenism reaction with increased requirements to transfusion, or their symptoms fail to be managed by transfusion. Another option, finally, is hematopoietic stem cell transplant and gene therapy. Now, the final question about thalassemias: can you name some of the oral versus parenteral iron chelators? Differiprone and deferoxyrox are the oral ones, and deferoxamine is the parenteral one. Now, returning to our normal hemoglobin electrophoresis part of the algorithm, we've already discussed the alpha thalassemia minor, but what's left is the sideroblastic anemia. So what are the differentials of microcytic anemia with normal to elevated serum iron and normal hemoglobin electrophoresis? One is alpha thalassemia minor and the other is sideroblastic anemia. Now, how do we differentiate these two conditions? We depend on PBS, presence of basophilic stippling on PBS, or if we needed, performing bone marrow biopsy and observing ring sideroblasts prove sideroblastic anemia. What do we see in iron studies? Increased serum iron levels. What's the other possibility than ring sideroblasts and basophilic stippling indicating sideroblastic anemia? Pappenheimer bodies. There are a different type of intraerythrocytic inclusions. What's TIBC level in sideroblastic anemia you expect? Well, we have high iron, so we have low TIBC. We already discussed the possible underlying causes. However, the ones that we did not discuss is the possibilities of sideroblastic anemia without microcytosis or hypochromia. Remember, presence of anemia plus ring sideroblast and basophilic stippling, if it is associated with macrovallocytes or hypercellular marrow or cytopenia, is referred to as myelodysplastic subtype of sideroblastic anemia. We discussed them in terms of myelodysplastic syndrome, the most important differential diagnosis of basophilic stippling and ring sideroblast. Second point is, even though we discussed X-linked cause, lead poisoning, B6 deficiency, or copper deficiency, remember the most common cause of sideroblastic anemia is alcohol. That's alcoholism. Now, talking about lead poisoning as an important underlying cause of sideroblastic anemia, what do we see and what workup should we include? We would order abdominal x-rays and lead levels, and as I mentioned in the beginning of iron deficiency anemia episode, we have two important differential diagnoses for increased free erythrocyte protoporphyrin level. One is iron deficiency anemia and the other is sideroblastic anemia due to lead poisoning. And why is it so? Very simple. If you review again the heme-synthetic pathway, you can see it here that the very last step of heme synthesis includes conversion of protoporphyrin to heme by the enzyme ferrochelatase. This enzyme is inhibited by lead poisoning or by absence of iron. That's in iron deficiency anemia. Protoporphyrin will build up. So that's why we say we have increased free erythrocyte protoporphyrin, in iron deficiency anemia and lead poisoning. Oh, by the way, you can see also here why we have copper deficiency as a mechanism of sideroblastic anemia. If I can draw your attention to this portion of the synthetic pathway, you can see that only Fe3+, the ferric iron, can be incorporated into heme by ferrochelatase. And so we need to convert the ferrous iron by the cytochrome oxidase, cytochrome C. This cytochrome oxidase C requires copper. So if this copper is deficient, we would not have ferric iron to be incorporated into heme synthesis, and again we will have impaired heme synthesis, also known as sideroblastic anemia. Now that we are here, it's worth it quickly reviewing the other steps of the heme synthetic pathway to have a better concept of this. So the very first step is ALA synthase, succinyl-CoA and glycine by the enzyme ALA synthase would produce ALA, the very first thing that we have it here. Now the very second step, in addition to the last step that we just talked about, could be inhibited by lead poisoning. But how about the first step? Okay, let me write it down here, this one, the ALA synthase. That is the one that requires vitamin B6, and therefore in patients taking isoniazid, this step could be impaired. That's why we say B6 deficiency is associated with sideroblastic anemia. Now, second step, the ALA dehydratase inhibited by lead poisoning. Now, we have next couple of steps that are associated with porphyrias. The first one is due to deficiency of porphobilinogen deaminase associated with acute intermittent porphyria in this step. So porphobilinogen would build up. We have acute abdominal pain, neuropathy, paranoia, and port wine colored urine, autosomal dominant mode of inheritance, but no photosensitivity. The next porphyria, porphyria cutanea tarda, happens in the next step, enzymatic deficiency, due to uroporphyrinogen decarboxylase deficiency associated with, the name indicates, cutaneous manifestations, the photosensitivity. The urine color is described as T-color. Then we have some intermediary pathway reactions, and then finally we have the very final one that we discussed. By the way, do you remember how do we treat some of these porphyrias? You remember the very first step, the ALA synthase could be inhibited by heme and glucose. So we give patient these inhibitors of rate-limiting enzyme. But if anything, just remember this very important portion of the heme synthetic pathway would help you answer a lot of questions about free erythrocyte protoporphyrin, why in sideroblastic anemia we have high serum iron, why copper deficiency causes sideroblastic anemia, and why lead poisoning causes sideroblastic anemia. Now, we are not discussing the treatment for lead poisoning. That's an acute, usually, poisoning scenario. But in case you want to just review that, remember the severe cases are managed by calcium EDTA or dimercaprol, while the mild to moderate cases are managed by Soximir. However, in general, what is the treatment of the sideroblastic anemia? We treat the underlying etiology. If the patient receives isoniazid, he needs to be supplemented with pyridoxine. That's one important arm of treatment for sideroblastic anemia. The other important arm, please remember this, similar to the transfusion-dependent or severe thalassemias who need iron chelators, here we also need iron chelation. Again, remember this portion, if iron is not incorporated into heme synthesis, its level would build up in the serum. This again helps us understand the approach to microcytic anemias to see why sideroblastic anemia is the one associated with increased serum iron. Now, I have to finish this episode by talking a little bit about myelodysplastic syndromes, because every time in every reference we hear ring sideroblast or basophilic stippling, we immediately hear sideroblastic anemia, myelodysplastic syndrome, lead poisoning, the three top differential diagnoses of these findings in PBS and bone marrow. Now, please be careful. Myelodysplastic syndrome is not a differential diagnosis of microcytic anemia. Yes, it's possible to have ring sideroblast and basophilic stippling, but not having the microcytic anemia. That's why some references categorize this as a myelodysplastic subtype of sideroblastic anemia that is not microcytic but Because of the presence of macrovalocytes, we say it is a type of macrocytic anemia. Now, what's the formula of myelodysplastic syndrome? Well, hypercellular marrow plus cytopenias plus ring sideroblast and basophilic stippling and macrovalocytes. However, if you are asked what's the most specific PBS finding of myelodysplastic syndrome, do you remember what was it? It was the pseudo-Pelger-Huet abnormality of neutrophils with less than 3 lobes, or so-called bilobed polymorphonuclear cells. The pseudo-Pelger-Huet abnormality. What's the pathogenesis of myelodysplastic syndrome? Remember, maturation arrest of non-lymphoid cell lines. And what is the hallmark in CBC? We could have basophilia. And what is the third complication? Transformation into acute myelogenous leukemia. Please remember just these 5 points. Hypercellular marrow, cytopenias, ring sideroblast and basophilic stippling, basophilia, and most importantly, pseudo-Pelger-Huet abnormality of bilobed neutrophils due to maturation arrest and possible transformation to AML. Pseudo-Pelger-Huet most commonly seen after initiation of chemotherapy. Thank you. This finishes our discussion of microcytic anemias.